Thank you. I think I talk better when I'm standing up, but thanks for the offer to sit. Okay, so I'm going to start the session talking about over and underdiagnosis of cow's milk allergy and how do we get it right. And here are my disclosures. And so the objectives of my talk today will be to talk about the prevalence of cow's milk allergy, pitfalls in diagnosis of cow's milk allergy, and then also the pitfalls relating to overdiagnosis and underdiagnosis. But I think, one of the things that we have to always remember is that cow's milk allergy is by far the most complex presentation of food allergy, particularly in early childhood. And I think that's why we have all these discussions, because when we have peanut allergy, it's pretty clear when a child eats peanut, they have symptoms within 2 hours. You can do a skin prick test or specific IgE to confirm the history. If needed, you can do a food challenge, which normally you can get done within 2 hours and just wait another hour, so the family is done in 3 hours. But when you get to cow's milk allergy, we have the IgE-mediated food allergy as peanut with the immediate type symptoms. But the vast majority of cow's milk allergy present under this umbrella of non-IgE-mediated food allergies. So we have the food protein-induced enterocolitis. I'm not going to go into detail. There's been many sessions about that in this meeting, which is, classically the acute vomiting 1 to 4 hours after ingestion. But even with that, when we wrote the international FPIES guidelines, we have had hundreds of emails about whether it's 1 to 4 hours or 2 to 4 hours. So you can see all the complexities relating to cow's milk allergy. We have eosinophilic diseases, and I'll show that again later, but as much as it's easy, more or less, to diagnose EOE by doing an endoscopy, the endoscopy is not going to tell you that the EOE is driven by cow's milk or egg or wheat, and that is taking a process of elimination and reintroduction. We have proctocolitis, which is classically the blood in stool, and then the mild to moderate non-IgE-mediated cow's milk allergy, which is milder forms of usually a combination of symptoms, which are all highlighted in the COMA score, which you will hear about in the other two talks as well. So really the symptoms of cow's milk allergy, it can be IgE-mediated, which is the skin, the GI tract, the respiratory tract. It's non-IgE-mediated, which again is the skin and the GI symptom. And really when we look at the bottom row, we can see that we have chronic acute urticaria, never chronic urticaria relating to food allergy. So acute urticaria, acute angioedema, colicky or abdominal pain, diarrhea, we have the lungs, the symptoms relating to the lungs, we have anaphylaxis, and then atopic dermatitis, and in the GI symptoms, the gastroesophageal reflux disease, blood or mucus in the stool, and then also faltering growth in the more severe instances. And here particularly, I think the symptoms that can be highly debatable is the colicky abdominal pain, it is the atopic dermatitis, and then also perhaps at what point is reflux troublesome enough to be associated with cow's milk allergy. Particularly now in the United States, we have to repeat over and over that atopic dermatitis causes food allergy, and food allergy does not cause atopic dermatitis. But getting back to what Jonathan Hurricane said yesterday, we really have to listen to every family and take their concerns into account. We do know that there are some cases of atopic dermatitis where they do not improve on sufficient topical treatment. We take milk out of the diet and the atopic dermatitis get better. At that point, you're going to have the discussion with the family. Are we going to keep the milk out at the risk of perhaps developing IgE-mediated cow's milk allergy later on, or are they going to have the milk in the diet and think about more, I would like to say, potent topical treatment, or perhaps treatment which by injection, such as a Dupixent, which you've heard about many times in this meeting as well. So cow's milk allergy prevalence, it differs quite a lot worldwide. You can see that, in Singapore, and also obviously age-related. So just the fact that I've got no data there for the Philippines doesn't mean that there's no cow smoke allergy in the Philippines. We've recently had the Apache conference in Singapore, where clearly we discussed, cow smoke allergy in infants in the Philippines, but the only data we have looking at prevalence is in teenagers. We can see some numbers in Singapore, and then it gradually really increased looking at data from China, the third line down, the UK, and then also the United States, which is data from Ruchi Gupta, which I think she's presenting at this meeting as well later on. We also recently did a systematic review. I'm one of the co-authors looking at cow smoke allergy prevalence in Europe. We looked at 93 studies. We concluded that self-reported cow smoke allergy was 5.7%, and that the point prevalence of cow smoke allergy based on oral food challenge outcome was 0.3%. But this 0.3 was actually much higher when we also included children who had clear symptoms, support